Today we'll discuss about cleft lip and palate. This is a second session. The first session dealt with the development of face, and today is the second session. We'll be discussing about cleft lip and palate, the classification, etiology, clinical features, and management. So primary palate and secondary palate, we had already discussed that in the previous session. So what is a cleft lip? It is a congenital anomaly with a split or a gap in the upper lip of one or both sides of the face. What's a cleft palate? It's a congenital anomaly with a split or a gap in the roof of the mouth. So cleft lip. It occurs due to failure of fusion, either between both the median nasal processes or between the maxillary process and the median nasal process on one or both sides. So it's of two types. You can have the incomplete cleft lip and the complete cleft lip. In the incomplete type, it does not extend into the nose or nasal cavity. In the complete type, it extends into the nasal cavity. Now, cleft palate. It occurs due to partial or complete failure of fusion of the two palatal processes or palatal shelves and the premaxilla. We already discussed that the line of fusion of the two palatal shelves and the premaxilla is in the shape of a Y. So there are two types. You have the complete cleft palate and the incomplete cleft palate. Complete is also known as type 1. Here the premaxilla and both the palatal processes do not fuse, and the nasal cavity and the mouth are interconnected. In the incomplete cleft palate or type 2, there is incomplete fusion of the premaxilla and the palatal processes. So in type 2A you have the bifid uvula, type 2B you have the bifid soft palate, and type 2C you have the bifid soft palate and the posterior part of hard palate. So this is one type of classification. Now the classification began as early as 1922. The Davis and Ritchie classification classified the cleft disease in relation to the position in relation to the alveolar process. So there were three groups or three classes. Group 1 is the pre-alveolar cleft, Group 2 is the post-alveolar cleft, and Group 3 is the alveolar cleft. Then the View classification 1931, that was classified into four classes or four groups. Group 1, the cleft involved only the soft palate. Group 2, the hard and the soft palate up to the incisive foramen. Group 3 means complete unilateral clefting of the soft palate, hard palate, lip and alveolar ridge. And Group 4 or Class 4 is complete bilateral cleft of soft palate, hard palate and or lip and alveolar ridge. So this is how it would like. The Group 1 means the soft palate. Group B means soft and hard palate up to the incisive foramen. The incisive foramen is in this area. It's sort of the junction between the primary and the secondary palate, or the premaxilla and the secondary palate. So this is a unilateral complete cleft of the lip, alveolar ridge, primary palate and or soft palate and hard palate. This is a bilateral cleft. You can see as the description. Then in 1962 there are another classification known as the American Cleft Palate Craniofacial Association, ACPA classification. It also classified into two types. You had the clefts of the prepalate, that is the lip and the primary palate, and clefts of the palate, that is the secondary palate. So under the prepalate you had cleft lip, also known as cheloschisis, cleft alveolus, alveoloschisis, and the cleft lip, alveolus and primary palate together known as the alveoloschisis. Now the clefts of the palate further classified into cleft of the hard palate known as uranoschisis, cleft of the soft palate staphyloschesis or veloschisis, and the cleft of the hard and soft together uranostaphyloschisis. So in 1971 the Kernighan's stripped Y classification was formulated. So here what they did was the entire line of fusion I mentioned earlier was the shape of a Y, and that area was uh, represented by blocks with numbers. And so here you can see the blocks. So 1 and 4 represent the lip, 2 and 5 represent the alveolar ridge, and 3 and 6 the hard palate anterior to the incisive foramen, and 7 and 8 is the hard palate, and the 9 is the soft palate. So depending on the involvement, you can either shade the colors and you can depict in this diagram. Now there was a Millard's modification of the Kernighan's classification, which again was popular during in the year 1977. Here what he did was he added additional 2 more blocks. So instead of the 9 blocks, you have the 11 blocks. He added the block 1 and 5, which represents as 2 opposing triangles. The upright one is known as the nasal, represent the nasal floor, and the upside down turned one is represent the nose. Now this classification, that is a Laschal classification, this is what I feel comfortable with. So it was also formulated in 1987. So Laschal, you can see again it's the shape of Y and there are blocks, but there are only 6 blocks. So you have the L standing for lip, A for alveolus, H for hard palate, then soft palate, then again hard palate, alveolus and lip. So that's how Laschal comes. So a capital letter represents complete cleft. A small letter represents incomplete cleft. A star represents minimally clefted, and a dot represents normal development, that is no cleft. So an example would be, if you had all capital letters, you would have written as LAHSHAL, Laschal. Bilateral complete cleft lip, complete cleft alveolus, and bilateral complete cleft palate. If it was LAHS capital and rest 3 are dots, it would have been a right complete cleft lip, complete alveolus, cleft alveolus, and a right complete cleft palate. Why the left side of the palate is normal? Palate, alveolus, and lip is normal. Similarly, if you wanted to show a left incomplete, then it would have been a initial right side would be all dots, and then you have the HS capital and AL. So this means that there is a left incomplete cleft lip, incomplete cleft alveolus, and a left complete cleft palate, and the right side is normal. So I think this is a more easier way of depicting it. So another classification which combines both. So you have the cleft lip alone, which can be unilateral, bilateral, or median, depending on the abnormality in the fusion. Now they can have a cleft of the primary palate only, that is the part of the hard palate which is in front of the incisive foramen. Complete means complete absence of the premaxilla. Incomplete means there is a small or a rudimentary premaxilla. In such a case, it can also be unilateral, bilateral, or median, and may be associated with the cleft lip. But in this case, only the primary palate. Cleft of the secondary palate, that means behind the incisive foramen. Again, you can have complete, incomplete, and a submucous variety. Complete means that the nasal septum and the vomer are separated from the palatine or palatal shelf or process. Incomplete means it is partially in some portions it is separated, in others it is normal. So it's an incomplete cleft of the secondary palate. Then the fourth one is a cleft of both primary and secondary palate, and the fifth is cleft lip and cleft palate together. So this is how the diagram looks. You can see the line of Y-shaped line of fusion going all the way up to the nasal floor. The lip, alveolus, anterior primary palate, hard palate, and soft palate together. Here you can see a unilateral cleft of the lip extending into the nasal floor. This is a bilateral cleft of the lip extending to the nasal. We can see it there clearly, very beautifully. Now here you see a cleft of the uvula, so it's a posterior defect. Then the uvula along with this, that is a soft and hard palate. Now this is a bilateral cleft palate. So these all are separately shown. Now here onwards, you can see a cleft involving the lip, extending the nasal floor, cleft of the alveolus, and the anterior palate or primary palate in front of anterior to the incisor foramen. Now this is a complete unilateral cleft of the lip, alveolus, anterior palate, and that is full palate. So it's a complete one on the left side as well as a complete clefting of the right palate as well. So this is a bilateral cleft of the lip, cleft of the alveolus, and the cleft of the anterior palate. And this is a bilateral cleft of the lip, alveolus, anterior palate, I mean the entire palate. So now let's go into the etiology. So even though we know that familial history, a positive family history, is a definite risk factor for the development of cleft in the next child. So it is more common in the case of cleft lip only and or combined cleft lip and palate. But I must say at this point that nearly 70% of the cases are usually sporadic. 50 to 70% is sporadic, and while the remainder can have a family history or a syndromic presentation. So protein and vitamin deficiency has been known to result in cleft disorders, rubella infection, radiation exposure, genetic abnormalities or chromosomal abnormalities, maternal smoking, maternal alcohol consumption during pregnancy, maternal epilepsy, drug intake during pregnancy like steroids, eptoin, and diazepam are also known to result in cleft lip and palate. Now a number of syndromes are there in which cleft lip or cleft palate is a part of it. So you have the Pierre-Robin syndrome or the Pierre-Robin sequence. Here you have an isolated cleft palate, micronathia, and a posterior displaced tongue. Klippel-Feil syndrome, again cleft palate and short neck. Short neck saying that there is a fusion of the cervical vertebra, resulting in short neck and difficulty in neck mobility. You have the Stickler syndrome, dental anomalies, joint hyperextensibility, hearing disorder, cleft disorder. The Sprinsen syndrome, again you can have a cardiac defect and a cleft disorder. Down syndrome, Eppert syndrome, Patau syndrome. Down syndrome is trisomy 21, Patau is trisomy 13, like that. The Treacher-Collins syndrome, again you have mandibular hyperplasia, ear deformities, eye asymmetry, and a cleft palate. So a number of symptoms and many more symptoms are there in which you have either a unilateral or bilateral cleft disorder. So clinical features is more common in Caucasians. It's unilateral 75% cases, and when unilateral is more common in the left side. Cleft lip alone is seen in 15 to 25% cases, and when it is so, it is more common in males. Cleft palate alone is seen in 25 to 40% cases, and when seen, it is more common in females. Combined cleft lip and cleft palate is more common and is seen in 50% of the cases, and the incidence is around 1 in 500 to 600 live births, and such a case is more common in males. So combined disorder is the most common variety. Combined is more common. Now, the presentation, the infant usually presents with difficulty in feeding, difficulty in suckling or sucking, difficulty in swallowing, and usually it happens immediately after birth. On examination, you will see a gap or a split either in the upper lip or the roof of the mouth. The speech becomes defective with difficulty in making sounds or creating sounds. You may have the child may present, infant may present the nasal speaking voice later on. There will be altered dentition or supernumerary teeth or dental abnormalities. The child presents with recurrent upper respiratory tract infections, recurrent ear infections, especially the middle ear, resulting in otitis media and later on chronic otitis media and hearing loss or hearing problems. Then along with it, you may have cosmetic problems due to the maxillary hyperplasia or the underdeveloped upper jaw. Then you will have problems associated with the other components of the syndrome, such as cardiac defects, gastrointestinal defects, neurological abnormalities, based on the type of syndrome it is. So it's a simple median cleft lip. So the cleft lip cannot see on this side. It's a very minute cleft lip or a microform cleft lip. This is an incomplete cleft lip, and this you can see a complete. That means it extends into the nasal floor, complete cleft lip. And when it involves the alveolus, you can see a cleft lip and alveolus. Now here it is a complete cleft lip and palate. You can see the tongue through it. You can see that though now when I say about cleft lip, you must understand that it also includes a cleft of the nose. So there is a nasal deformity that simultaneously comes with a lip deformity. Now in the bilateral spectrum, again the same thing. You can have bilateral incomplete cleft lip, bilateral complete, or you can have incomplete on one side and complete on the other side. Then you can have a complete cleft lip with a palate, bilateral. So diagnosis. So traditionally diagnosis is at the time of birth by physical examination. But over the last years, prenatal diagnosis is possible due to the advent of ultrasound. So by ultrasound, and today you have the 3D and 4D ultrasound, you can identify cleft lip or cleft palate in utero. Then when identified, an amniotic fluid study will be done to rule out for genetic studies for chromosomal abnormalities. So what's the treatment of cleft lip? Surgery is the treatment of choice. So as soon as a child is born, there is an assessment of the child from which you diagnose whether it's a non-syndromic or syndromic type of cleft disorder, and then the pre-surgical evaluation begins. You monitor the weight gain of the baby and whether the child is able to get adequate nutrition. Then the surgery for cleft lip repair is usually planned ideally at the 3 months, but it can go up from 3 to 6 months. That means you can also have the option today that to do a pre-surgical orthopedic treatment to prepare the infant for the surgical repair of the cleft lip. So there is something known as the nasoalveolar molding devices or appliances. Using that, it can reduce the severity of the cleft and the nasal deformity and helps in attaining good results post-surgery, surgical repair of the cleft lip. Then you train the child or the infant for suckling, swallowing and speech. You can adopt various feeding strategies like using special bottle nipples or using a feeding obturator if there is a cleft palate along with the cleft lip. By using the obturator, it sort of separates the nasal cavity from the oral cavity and thereby help in feeding. Then if an infection is present, control and treat the infection. Now in the case of middle ear infection, can be prevented by placing a ventilation tube or a ear tube in to ventilate the middle ear. So these are the special feeding bottles. This is a Haberman feeder, this is a squeeze bottle, and this is a angled nipple. You can see a pigeon feeder, and here you can see the small blue ventilation tube placed in the tympanic membrane to ventilate the middle ear. This is the middle ear, and this is the eustachian tube going down. Here it's going down, and that connects it to the oral cavity. So the criteria, so Millard's criteria is used to undertake surgery for a cleft lip. The rule of 10. The baby must have a weight of at least 10 pounds and should be 10 weeks old and should have a blood hemoglobin of 10 gram%. So that means around 3 months is the ideal time for to perform the surgery. You can do a one-stage surgery which is done at 3 months for unilateral or bilateral. I can go for a 2-stage, do on one side then do on the other side in the case of cleft lip alone. If it is a combined cleft lip and palate, you might have to do more than one operation or 2-stage operation in which you deal the cleft lip and the soft palate in the 3 to 6 month period, and if possible even place the ventilation tube in the middle ear to ventilate the middle ear, or else, and then the second surgery is done for the hard palate, and that is done around 9 to 18 months. So the common surgical technique used for repair of the cleft lip in the case of unilateral is the Millard's rotation advancement flap, and in the case of bilateral cleft lip, you can use the view 3 method or the Millard's single stage method or a Manchester method, and a number of methods are there. So the markings are usually done prior to surgery, and in the case of cleft lip, a 3-layer repair is usually done where the muscles are repaired, the mucosa is repaired, and the skin is repaired. Now here, along with the cleft lip repair, a primary rhinoplasty is also done to manage the nasal deformity. Now, along with this, if there is an associated primary or secondary cleft palate disorder, that also should be managed. So this is the Millard rotation advancement flap. A is the advancement flap, C is the flap, and R is the rotation flap. So these are the three elements, A, C and R. And this is how the scar looks. So the treatment of cleft palate. Again, the Millard's criteria can be extended to the cleft palate. The rule of 10, you have the baby should be 10 kilos of weight, 10 months of age, and a hemoglobin level of 10 gram percent. So the repair is also usually done around 1 year, that is 10 to 18 months. Early repair can result in a retarded maxillary growth, and late repair will result in speech defects or speech difficulty or abnormalities. Both the soft and the hard palate are repaired. So there is no single surgical technique which is universal, and the goal of the procedure is to separate the oral cavity from the nasal cavity and to make sure that there is watertight closure. Then the repair of the muscles within the soft palate is must in order to allow for normal speech development. The number of surgical techniques are there. The popular ones are the Furlow's palatoplasty, the von Langenbach technique, the two flap technique. So this is the reverse Z plasty or the Furlow's palatoplasty. So you can see the two incisions are placed. This is a soft palate cleft or a soft and hard palate cleft. So you can see the Z incisions placed. Flaps are raised. Similarly, underneath flaps are also raised, and they are crisscrossed and sutured. And you can see the Z-shaped incision here. See, so it's a double opposing reverse Z plasty. Now this is the Langenbach technique. Here again, around the palate, the incision is made around the palatal defect, and then you make two lateral incisions just medial to the alveolus, and then the midline is approximated, and then the mucosa is also approximated. So mucoperiosteal flaps are raised in the case of von Langenbach technique. Relatively simple technique. This is how the real picture looks like. You can see the two cuts made here, one in the midline and two on either side, and then the suturing. And this is how the scar will look at the end. And this is the two flap technique. Two flaps are raised on either side of the palatal defect, and then the suturing is done. Here again, this area is left raw to heal. So this is how it looks like. You can see the palatal defect over here, and the two flaps are raised on either side, and then you suture it. So laterally on both sides there will be a raw surface which will heal while the defect is closed. This is the two flap technique. So saying this, I want you to understand that children with a cleft lip or a palate or cleft palate will need several treatments and assessments, including several surgical procedures as they grow up. Usually all these will go on up to the age of 18 to 20 years. So it's not one stage or two stage procedures. You will have multiple surgeries catering to multiple abnormalities. So hearing problems. Child may need hearing aids, surgeries to control the ear infection, surgery to place the ear tubes. Ideal time is to do it along with the cleft lip repair, but if you haven't done it, then along with the hard palate repair. Speech problems, you may have speech therapy, speech devices, and later on in life, you may have to go through a pharyngoplasty or a veloplasty. For the dental problems throughout the early childhood, orthodontic evaluation and treatment is required. Tooth extraction, alignment by placing braces, and later on alveolar bone grafting is done to fill the alveolus gaps due to the cleft disorder. Dental implants, and towards the 16 or 18 years of age, maxillary osteotomy has to be done to correct the maxillary hyperplasia, or maxillary advancement is done. Now for the nasal deformity, I told you the primary rhinoplasty is done at the time of cleft repair. Then you have to do an intermediate rhinoplasty around the 3 to 5 years age, At the same time, you can do a lip revision at the same time, because the treatment of the lip and the nasal cavity are synchronous to each other. And then later on, at the age of 16 to 18 years, a second rhinoplasty is done for the final correction of the facial appearance. So this is how a flowchart would be. Child is born, then at around 3 months you plan the cleft repair along with the primary rhinoplasty, and prior to the 3 months you can do the nasoalveolar molding so that it can aid in the cleft repair. Then around 9 to 18 months you plan for the palatoplasty, and along with that you can plan intermediate rhinoplasty later on around 3 to 5 years. At the same point you can plan a intermediate rhinoplasty. Along with that you can do a lip revision. Then around 7 to 12 years, the primary orthodontic evaluation, tooth extraction, dental alignment by braces. Then around 8 to 9, 10 years, you can do the alveolar bone grafting. Then orthognathic surgery usually begins from 14 to 16 years of age. Along with that, you can go ahead with a secondary rhinoplasty. So by the age of 18 years, ideally, most of the surgeries will be done so that the person can have a near normal adult life. So this is how it looks like. It's the same thing in the flow chart. So cleft lip after surgery, cleft palate and after surgery. So this picture here shows the von Langenbach technique. By seeing the scars itself, you can make it out. So thank you. So this is a brief description of the cleft lip and cleft palate. There are much more techniques and how to do it, and it's a vast topic. So thank you.